my topic today is about myelofibrosis newcomers. I will go through the evolving understanding of genetics in MPN, the evolving understanding of genetics of MPN, the current FDA-approved treatment armamentarium for myelofibrosis, where we stand with JAK2 inhibitors, what is the unmet needs in patients with myelofibrosis, and describe how novel therapies may address these needs. Myeloproliferative is a clonal hematopoietic stem cell disorder due to driver mutation carried in MPL than JAK2 and non-driver mutation like ASXL1, ESH1 and 2, and IDH1 and 2, and SFRS2, which leads to either essential thrombocythemia, polycythemia vera, or myelofibrosis, either primary or secondary to both ET or BV, with progressive symptoms, cytopenias, organomegaly, huge splenomegaly, and the catastrophe is the transformation into acute myeloid leukemia. As we see here, regarding the frequency of the driver mutation, JAK2 is the most common driver mutation in myelofibrosis, and regarding the molecular risk aberration, the ASXL1 is the most common one. And there is an impact for these driver mutations and the non-driver mutation regarding the overall survival of these patients. The best one is the K-reticulin mutation, followed by JAK2 mutation, and the dismal one is the triple negativity, and also the high molecular risk, either ASXL1, IDH, EZH1 and 2, and the more complex is with 2 or more high molecular mutation, also worsen the survival. All of us know that the only curative therapy for myelofibrosis till now is the hematopoietic stem cell transplant. And the treatment is go for inhibition of the JAK2 and inhibition of the secondary inflammatory state and less nutritional symptoms, inhibition of the clonal proliferation and the leukemic transformation, and the inhibition of external hematopoiesis, and the most common one is the huge splenomegaly. Currently, there are 2 approved FDA treatment therapies for myelofibrosis. The first one is ruxolitinib, the second one is the fedratinib. Ruxolitinib approved upon the 2 trials, COMFORT-1 and COMFORT-2. In COMFORT-1, there is a head-to-head comparison between ruxolitinib and placebo. In COMFORT-2, again, it's the best available therapy, and this in terms of the spleen volume response and the symptom improvement. Regarding fedratinib, it is approved in the front-line setting in the case of Jakarta study, and in second line after ruxolitinib failure in Jakarta 2 study, and it demonstrated the efficacy regarding the spleen response and the symptom response. We will go through our case today, how to manage a case with myelofibrosis. Our patient today is 78-year-old male, diagnosed as primary myelofibrosis 3 years ago, complaining of easy fatigue, progressive left upper quadrant pain, weight loss, and night sweat. Spleen was 5 centimeters below the costal margin. Regarding the blood count, TLC was 11,000 with leukoerythroblastic reaction. Hemoglobin was low, 7.5 gram per deciliter, and the platelets was 90,000. Regarding the driver mutation, it was JAK2 positive with normal karyotyping and ASX1 positivity. So we are dealing with a high-risk primary myelofibrosis and anemia, thrombocytopenia, splenomegaly, and the MPN 10 score of our patient is 40/100. What will we do? According to the NCCN guidelines, last version 2/2021 that published 2 months ago, it said that when you are dealing with a high-risk patient, the first thing is go for MPN 10 score. After that, if the platelets is below 50, if he is a candidate for transplant, we will go for transplant. If no, we can go for clinical trial. In our case, platelets more than 50, so we are candidate either for ruxolitinib or fedratinib. What about the anemia? We should go for measuring the serum erythropoietin. If below 500, we can add either short-acting or long-acting. If above, we can combine treatment in the form of danazoles, lenalidomide, thalidomide, plus or minus prednisolone and luspatercept. What about the real-world survival among patients who are receiving the ruxolitinib? In the US survival data, as we see here in green, there is a survival before approval of the ruxolitinib. In the orange one, after approval of ruxolitinib, but not taking ruxolitinib, and in the blue one, after taking the ruxolitinib, as we see here, there is a strong difference between usage ruxolitinib and without ruxolitinib. And the recently published in EHA, last EHA, the European experience according to the usage of JAK2 inhibitor ruxolitinib versus best available therapy, and it was statistically significant in the overall survival between both. Not only for ruxolitinib. As we see here, then in last EHA, the update regarding the overall survival and the progression-free survival of the fedratinib, it showed that fedratinib significantly reduced the risk of disease progression versus placebo. How to start the ruxolitinib dosing? If we have patient with platelet more than 200, we can give 20 milligrams twice a day. Between 100 to 200, we can give 15 milligrams twice a day. 50 to 100, 10 milligrams twice a day. Below 50, don't start. So we are starting ruxolitinib 10 milligrams twice daily, then up titrate the dose according to the blood picture and the response, and after that the patient attaining a response regarding symptoms. MPN 10 was 10 instead of 40 before. The spleen, it was normal and with a stable blood count. ولكن للأسف بعد 3 سنين من استخدام الروكسولوتينيب البيشنت relapsed again. The symptoms recurred and the MPN 10 score 50 over 100, and the spleen become more bigger, 10 centimeter below costal margin, with more profound anemia and thrombocytopenia. So what will you do? How to define the ruxolitinib failure? There is no solid guidelines till now to define the ruxolitinib failure, but we will go to assess according to the spleen response and the symptom response. If we have patients that didn't attain in a response regarding the symptoms or the spleen, it is the primary resistance. If patient attaining a response then lost this response, as our patient, it is a secondary resistance. In case of intolerance, either hematological or non-hematological, is called ruxolitinib intolerance. And in case of transformation to blast phase or progression of the spleen size more than 25% from the baseline, it is the progression. But take care, we need a minimum 12 weeks of tolerated dose more than 200 twice a day of ruxolitinib before saying that. What about the NCCN in case of ruxolitinib failure, either intolerance or resistance? We can go for, first thing is a clinical trial. Second thing, we can shift to another JAK2 inhibitor, which is fedratinib, and there is the recent published data according to the effective option of myelofibrosis progressing after the ruxolitinib, and I think that with progression of time, it will attain progression and overall survival like ruxolitinib. Unfortunately, approximately 10 to 20% of patients with high-risk myelofibrosis are ineligible for ruxolitinib or fedratinib because of cytopenias. So we will go for the third comer of JAK2 inhibitor is the momelotinib. Momelotinib is JAK1 and JAK2 inhibitor and also ACVR inhibitor, which leads to reduced hepcidin, which leads to in restoration of iron hemostasis and the improvement of anemia. It is tried in Simplify 1 and in Simplify 2. In Simplify 2, there is a previously treated patient with ruxolitinib and attaining response regarding spleen and regarding symptom in a statistically significant manner. And in patient of JAK2 naive, there is a non-inferiority study. We attaining the spleen response, but regarding the symptom, non-inferiority not met. But the most important thing is the elevation of the anemia. As we see here at 6 months, there is 67% transfusion independence in momelotinib arm in versus of about 50% in patients receiving placebo or receiving ruxolitinib, and it is maintained for up to more than 3 years. Regarding the Simplify 2, also there is a transfusion independency reaching up to 45% in comparison with 21% in the placebo arm. All of us know that transfusion dependency and the anemia, it worsens the survival. And according to the analysis of Simplify 1 and 2, as we see here, there is a statistically significant overall survival benefit for transfusion independency and the responding patient versus patient who are not responding. So momelotinib now in phase 3 trial tested against danazol in a phase 3 trial momentum trial in treatment of anemia in myelofibrosis, and we are waiting for results. The fourth comer is the pacritinib. Pacritinib is not only a JAK2 inhibitor, it also inhibits the FLT3, IRAK1 and CSF1, and it is investigated in PERSIST-1 and PERSIST-2, and it achieving the response regarding the spleen volume and the symptoms, especially in patients with thrombocytopenia less than 50,000, and the most common side effect is the anemia and the thrombocytopenia, but it is less profound than other JAK2 inhibitor. And now this is in Pacifica trial, which is a phase C trial for patients with myelofibrosis platelet count less than 50,000. When you are comparing the 4 JAK2 inhibitors, all of them 4 categories achieving spleen reduction and symptom mitigation. Regarding anemia, momelotinib is the best one. Regarding thrombocytopenia, pacritinib is the best one. And we are going to talk about the survival benefit, established survival benefit for long-term analysis of Comfort 1 and Comfort 2 for ruxolitinib, and we are waiting for the results of fedratinib. Despite the improvement in the symptom, in the quality of life, in the spleen reduction, but there is several unmet needs in patients with myelofibrosis. JAK2 inhibition leads to on-target myelosuppression, may leads to more thrombocytopenia, more anemia, and the targeting JAK state pathway, it didn't reduce the possibility of transformation to the blast phase and accelerated phase, and it was illustrated in long-term follow-up in Comfort 1 and the Comfort 2. There is no difference between the ruxolitinib arm and the best available therapy arm, but there is a dismal outcome, the survival about 12 to 15 months after discontinuation of ruxolitinib. Therefore, we should think outside the box and we should target the outside the JAK state pathway. As we see here, we can target the transforming growth factor beta. We can go inside the cell, we target PI3K. We can target the apoptosis and BCL2 family. We can target inside the nucleus like telomerase inhibitor or PET inhibitors. Let's go to the apoptosis. BCL2 family are proteins with anti-apoptotic regulators. BCL-XL is one of these family, and JAK state pathway activation increase the expression of BCL2, BCL-XL in those patients. So navitoclax has been explored in combination with ruxolitinib in phase 2 study in about 34 patients after ruxolitinib failure, and achieving the spleen response and the symptom response, and also there is 30% achieve a regression of the myelofibrosis, and the most common side effect is thrombocytopenia, diarrhea, and fatigue. Not only that, symptoms, quality of life, spleen fibrosis, but also targeting the mutation variant allele. There is a decrease in 5 patients of 39 patients, more than 20% of the allele burden in those patients, and importantly, that patient with high molecular risk variants and mutation doesn't affect the response regarding the spleen or the symptom or the regression of the fibrosis of the marrow. There is ongoing trial of combination of navitoclax, ruxolitinib, either in ruxolitinib JAK2 naive or previously treated. The second one is targeting the epigenetic regulators. The first one is the BET family. As we all know, with activation of the JAK state and BET, there is upregulation of transforming growth factor beta, of nuclear factor kappa B, PCL2, and c-MEC, which leads to apparent erythroid and megakaryocytic differentiation, the presence of cytokine manifestations and bone marrow fibrosis. Upon inhibition, we suppress the cytokine production, so less fibrosis, so less symptoms related to the cytokine storm, and we will promote erythroid and megakaryocytic differentiation. And it was studied in the manifest study. It contained 3-arm study. The first one in patient with refractory or intolerant to JAK2 inhibitor. The second arm is add-on in case of suboptimal response to ruxolitinib, and the third arm is the JAK2 naive patients with no prior use as a front line. And the exciting data came from the third arm. The median spleen volume reduction, it was 50% and 67%, achieving more than 35 reduction in the spleen, and the symptoms in reduction more than 50% in 57 of patients. And importantly, there is 33 patients achieving regression of the fibrosis of at least 1 grade. There is a manifest study, now phase 3 study, including more than 300 patients in patient JAK2 naive to ruxolitinib with either this drug. The second one in the epigenetic modifiers is the lysine-specific demethylase 1, and it requires for normal hematopoiesis. Upon the blockage of the LSD1, there is a downregulation of malignant proliferation. There is inhibition of the growth factor, tumor growth factor beta, which leads to less myofibroblast, less fibrosis, less extramedullary hematopoiesis, and less splenomegaly. In case of inhibition of inflammatory cytokines, mostly interleukin 8, it will lead to less constitutional symptoms. The booming one is bomedemstat, which investigated in phase 1-2 trial, including myelofibrosis in JAK2 resistant or intolerant either ruxolitinib or fedratinib, and 51 of them harboring high molecular risk mutation. So it is the very high risk. Either it is a high risk myelofibrosis, it is resistant intolerant to JAK2 inhibitors, and also harboring more than 50% of the high molecular risk mutation. لسه باقي لي في وقتي 10 minutes. كام؟ 8 minutes. انا هعمل بالظبط يا دكتوره ميرفت ال 20 دقيقه بالظبط. Regarding the symptom improvement at week 12, there is a 73% achieving spleen reduction, 24% of them achieving more than 35 reduction in the spleen, and after doubling after 6 months, there is a 94 decrease in the spleen, and 31% of them achieving the target of 35 decrease in the spleen volume. Regarding the spleen, there is about 89% decreasing in the spleen, and also the mutant allele frequency, as we see here that 44% of patients decreasing the allele. We have 47 patients stable and only 9 of them progressing. The third one, when we target the nucleus, is the telomerase, which is inactive in normal cells and inactivated in many cancer cells. And the telomere length is globally shortened in CD30 for hematopoietic cells, but in case of patient with MPN, the telomerase activity is frequently upregulated. So in EMPARC study, when using imetelstat as the telomerase inhibitor in phase 2 study in 2 doses, large dose 9.4 IV versus 4.7 every 3 weeks, as we see here that the high dose achieving response than the lower dose, and the most important thing that the median overall survival in those patients 28 months in higher dose and 20 months in the low dose. So the improving survival in higher dose significantly correlated with the improved fibrosis, and after this study it will be a disease modifying drug. This is the most important study now. This is the phase 3 study comparing patients with refractory to JAK2 inhibitors in high-risk patient, imetelstat versus best available therapy after exclusion of JAK2 inhibitors. It is the first trial in high-risk patient resistant with molecular mutations to target the primary endpoint in the overall survival benefit in those category of patients. The last one is the transforming growth factor beta, and it, in preclinical studies, showed that decreased the proliferation of mesenchymal cells and type 1 collagen synthesis and depletion of myelofibrosis JAK2 mutated mononuclear cells. And all of us know that luspatercept, which one of its family approved in the low-risk treatment of low-risk MDS and in thalassemia, and also it is explored in anemic patient with myelofibrosis in phase 2 study with ruxolitinib, and achieving either elevation of the hemoglobin in transfusion-independent patient and transfusion independency in patient with transfusion dependency, either with ruxolitinib or without ruxolitinib. To conclude, we have an immediate and chronic goals for treatment of myelofibrosis. First of them is the reduction of the spleen volume. Second thing is the improvement of symptoms, improvement of blood counts, and prevention of complication, either thrombosis or bleeding. And the ultimate goal is the prolongation of progression-free survival, improvement in overall survival, and normalization of bone marrow fibrosis, and eventually the disease cure. Optimal definition of ruxolitinib failure or intolerance till now remained undefined. Treatment options with ruxolitinib failure and intolerance is unmet needs. Patient with persistent splenomegaly and symptoms, we can consider combination therapy or usage of fedratinib. For patients with cytopenias and JAK2 inhibitors, pacritinib and immunoretriv may hold promise. Therapeutic development has moved targets beyond the JAK state signaling pathway and deplete the myelofibrosis stem cells and impart a positive impact on natural history of the disease. And for that, thank you.